Was given this honor because Dr. Katz is in the gulag, and I thought I'd have to weigh this, but I couldn't find a scale big enough to weigh Dr. Sherman's CV in my office anyway. Dr. Sherman's been at the institution for a long time, just about as long as I have, and I've learned a great deal from him over the years as a medical student, house staff, fellow, and faculty. And it was really a privilege to have him come to talk to us today. He's really a world-renowned expert on stroke. He's, amongst all of this tome that I was given as a CV, I was fascinated to see that you were a lieutenant commander in the Navy. And I thought that was really nice. I have a great connection with that through my parents. My father was in the Navy, my mother was in the Navy, my father-in-law was in the Navy. Go Navy, beat Army. So with that, Dr. Sherman will talk with us on prevention of stroke.
Okay, thank you. Thanks for inviting me. What I wanted to do was, let's see, talk about stroke prevention strategies, run through a bit of some background on risk factors for stroke, and try to focus on the newer studies that have become available in the last year or two that I think are of clinical relevance. First, to start with, you mind if I sit down? Is it customary for speakers to sit?
Whatever you want to do.
To stand? Just in terms of background, stroke is still a very, as you are well aware, a common disorder in this country. 160,000 deaths per year estimated by the American Heart. 700,000 new or recurrent strokes this year. And that number's been increasing in recent years, which seems a little odd if we're doing so much better in preventing stroke. And the answer is what you guys do, and that is that our population is aging. And stroke is predominantly a disorder of older individuals. And so, in fact, the absolute number of strokes is increasing and will continue to increase as the population ages. So about every 45 seconds there'll be a new stroke in the United States, and it's an unusual family that hasn't been touched by a relative or a close friend who's suffered a stroke, and so they have a first-hand knowledge of the implications. And if you poll particularly older individuals, many of them have their greatest fear of a stroke, as opposed to the other major causes of morbidity and mortality, stroke, heart disease, or cancer. And I think it's because of the obvious loss of independence, the loss of the ability to speak, paralysis, dependence on others, etc. is feared more than the risks of coronary disease or cancer. Now, stroke is not a single entity, and therefore we have to fashion our preventive strategies based on what we see as a likely mechanism for the stroke. And this is just an overview. On the left, the minority of patients, about 15 to 20% who have hemorrhagic stroke, intracerebral hemorrhage being most common, and then subarachnoid hemorrhage in the remainder. Intracerebral hemorrhage most often seen with hypertension, but also amyloid angiopathy as a cause in the other In the right-hand side, you see the ischemic stroke patients, and that's really what I'm focusing on today. About 85% of the patients that we see with stroke have ischemic mechanisms. Lacunar small vessel occlusive strokes are responsible for about 25% overall, but in San Antonio, it's more like 35 or 40%. The reason being we have such a large population of patients with hypertension and diabetes, which is the substrate for these small artery occlusive events. So we have a disproportionate number of patients with lacunar strokes and the complications of multi-infarct dementia that are oftentimes associated with it. About 30% of patients will have large artery or median artery atherosclerotic vascular occlusive disease as the presumed mechanism for their stroke. About 1 in 5 will have a cardiogenic source for their stroke, and I'll talk a little bit about atrial fib. And then about 25% of the time, we don't come up with a specific mechanism, which is not surprising. I mean, it may be a vascular origin that's in the aorta or one of the extracranial intracranial vessels, maybe an embolus that's now gone, and so we don't specifically decide. So what are the strategies available to us? And the most important one is really risk factor identification and reduction, and I'll talk a little bit about that. We can encourage our patients to make some lifestyle changes, which are specifically smoking cessation, attention to their diet and exercise, and attention to the amount of alcohol they drink. The story with alcohol is a J-shaped curve like it is with coronary disease, so that regular amounts of modest amounts of alcohol are protected. Excessive amounts of alcohol increase risk of stroke, both ischemic and hemorrhagic, and people who don't drink at all have a slightly higher risk of ischemic stroke. Antithrombotic therapy, I'll spend a fair amount of time talking about that because there are a number of studies that have come to light and finished in the last couple of years, and I'll try to focus on those. Most of the antithrombotic therapy that we use is antiplatelet therapy. We have 3 agents available to us now: aspirin, clopidogrel, and the combination of extended-release diclofenac and aspirin and Agronox. And then anticoagulation still has an important role in certain specific at-risk patients, and I'll talk about some of the studies that have narrowed the spectrum of patients who are benefited by anticoagulation. Inappropriate patients, revascularization studies with endarterectomy, and now widely used carotid stenting, sometimes in the setting of a randomized clinical trial, oftentimes not in that setting, it's just done. And then I'll talk about some studies that address the issue of ACE inhibitors, ARBs, and the use of statins. Generally, when we think about the risk factors for stroke, we divide them into those that we can modify and that we cannot modify. The non-modifiable ones are the fact that we get older, that at any given age, men are at greater risk than women. However, if you look at the old population, many more women are having strokes than men because there are more women. And if you look at the absolute number of strokes, overall, there are as many in women as there are in men. So this is not a disorder that's really confined to men. Particularly the 2 ends of the spectrum, the very young and the very old, seem to have a predominance of women, based on mechanisms. The very old women have a lot of atrial fib and cardiogenic strokes. The young women have strokes related to pregnancy and migraine and other issues. And then the modifiable risk factors are listed on the left there. If you're strict adherent to evidence-based medicine. Some of these you might take issue with. Diabetes, say, for example, would be one. We all believe, most of us believe, that good control of diabetes is beneficial in preventing particularly these small artery occlusive events. But if you ask me for hard and fast, good, well-designed clinical trials that prove that, I'd be hard-pressed to give those to you. What we do know is that if you have poorly controlled diabetes and hyperglycemia and you have an ischemic stroke, your mortality and your morbidity is increased. And this is confirmed in animal models of ischemic stroke. You create an ischemic stroke in an animal model and you do preparations that have hyperglycemia and not. The hyperglycemic animals are much more likely to die and much more likely to have persistent neurologic trauma. Okay, what is this? Lipids and stroke. For a long, long time, there's been very clear evidence of a relationship with coronary disease. The relationship in the epidemiologic studies of cholesterol and LDL with stroke has been less certain. And it's thought that, and it's probably true, that much of the reason for that is if you have, there's a linear relationship of LDL risk, LDL level, and risk for ischemic stroke, but there's also a relationship in the population studies that have been done, looking at very low LDLs and an increased risk for brain hemorrhage. So that the idea is that perhaps one of the reasons why this relationship that is shown with coronary disease isn't so easily shown with stroke is because it's confounded by the fact that if your LDL is too low, you have an increased hemorrhage rate. If it's too high, you have an increased ischemic stroke rate. The mortality is increased in the hemorrhage patients. And oftentimes these large population studies just look at mortality and causes of mortality. But the study that really addressed this is the Sparkle study, which was published this year. And this is a study of patients who had previous stroke, 4,730 of them, no history of coronary disease, and they had LDL levels between 100 and 190. And they were randomized to atorvastatin or placebo and followed for about 6 years. The therapy was effective. You can see the different levels in the treatment group. The level in the placebo group, the LDL level was 129. In the statin-treated group, it was 73. So there was a significant difference in the two, which is a problem with some of the trials because there's so many crossovers. That it's hard to judge benefit. In this study, there was a 16% statistically significant reduction in stroke, and there was a 35% reduction in cardiovascular events. So in the course of the study, which is a 6-year follow-up, the number needed to treat in 5 years for preventing a stroke was 46. And it was 29 to prevent one major cardiovascular event. So this is the first study that's really given us good evidence that now it's beneficial in our patients to add a statin in the patients who have TIA or stroke. The hypertension story, I'm not going to go into all of the ACE and ARB story, because you're familiar with the HOPE study and the LIFE study. And basically these studies suggested that there was a benefit in patients with stroke who were placed on an ACE inhibitor or an ARB. The trouble with some of these studies was they were compared to placebo, and so there was a difference in blood pressure. The arguments were made that the reductions were greater than you'd expect, based on the blood pressure differences, and therefore it must be a unique effect of the drug or the class of drugs. The ALL-HAT study, however, 33,000 patients with hypertension, suggested that actually the group that did the best in terms of stroke reduction was the thiazide group, or thiazide group. And they had a slightly lower blood pressure. And so it caused a lot of people to kind of rethink this wave of enthusiasm that was being seen for ACEs and ARBs. While they probably are good therapies, it emphasized that probably the most important thing is to get the blood pressure. And that nuanced differences in drugs and classes of drugs are maybe less important than the fact that you're getting the blood pressure a few millimeters less. And if that's affected by using a chlorthalidone as opposed to amlodipine or lisinopril, and all the better. So the all-happen study kind of raised a question about whether ACE inhibitors or ARBs should be given to all patients with stroke, pretty much irrespective of their blood pressure status. The guidelines have not come out to make a firm statement recommending ACEs and ARBs following stroke, so that remains to be seen what happens. So, as I mentioned in kind of the introduction, antiplatelet agents are really the most common agents that we use. Everybody should, with stroke, unless there's some strong contraindication, should be on some kind of antithrombotic agent. And most all of those are going to be on an antiplatelet agent. And this includes our patients with small artery and lacunar strokes, those with extracranial or intracranial atherosclerotic vascular disease. The people with cardioembolic stroke typically should be treated with warfarin, but if it's not possible because of risks or other things, then they're treated with an antiplatelet agent. The cryptogenic strokes are treated with an antiplatelet agent. So really it's the majority, 80% or more of the stroke patients that we see, we have to make a decision about what antiplatelet agent to use. So here, this series of cartoons addresses the theoretical background for why antiplatelet agents might be effective. And you see the first frame up on the left emphasizes that as in the coronary circulation, it's thought, and there's evidence now from looking at carotid plaques in symptomatic and asymptomatic patients, that the important pathologic feature is a fissure or break in the surface of the plaque that exposes the lipid core, that then leads to adhesion of platelets, activation of platelets, further aggregation and cross-linking with fibrinogen, and finally a platelet-rich thrombus. In stroke and TIA, we believe that, and the evidence suggests that the major mechanism is really not an occlusive thrombus, but an embolus that occurs from this platelet-rich thrombus. This is a cartoon of a platelet showing the different sites of action of platelet inhibitory effects: aspirin inhibiting thromboxane A2 production, clopidogrel and ticlopidine inhibiting the ADP receptor. Aspirin, clopidogrel, ticlopidine all have irreversible effects on the platelet. So once the platelet is exposed to these antiplatelet agents, the platelet is affected for the life of that platelet, 9 days. Dipyridamole is a little different in that it has a reversible effect on the platelets. So that if the plasma level drops below a critical level, the platelets are no longer adequately inhibited. So that contrasts that to aspirin and clopidogrel. Dipyridamole affects the phosphodiesterase receptor and also adenosine, and has some other kind of local effects and a multitude of potential effects. What about aspirin? If you look at the meta-analysis that have been done in different vascular disorders, it's fairly consistent that aspirin reduces the risk by about 20% for recurrent stroke and other cardiovascular events. The lowest recommended dose shown by clinical trials is 50 milligrams a day. The recommended range by the FDA and the various guidelines is 50 to 325 a day. However, as has been around for some time now, there is a lingering controversy about the proper dose of aspirin, and it now is focused on whether or not there are patients who are aspirin resistant. And the current basis for this is if you take a group of patients, say that you're treating with 81 milligrams of aspirin a day for secondary stroke prevention, and you draw some blood from them and you analyze their platelets in one of these newer gadgets that measures platelet aggregation, about 25% of the time you would find that their platelets aren't adequately inhibited. And this is called aspirin resistance. Now, I think you have to look at this with a bit of caution, and the most important cautionary note is that this is a laboratory test, and while it might make some biological sense that it's going to be related to an increased risk for clinical outcomes, that hasn't been shown. So we haven't had a trial where we've looked at platelet aggregation studies in a group of patients on an antiplatelet agent and then not done something to intervene except keep them on their antiplatelet therapy and follow them to see if it actually does predict people who are at increased risk for vascular disease. We don't know what happens to these platelet aggregation studies very well over the course of time. And thirdly, if you take these different measures, these different machines, and you put the same blood in them, you get different responses in different machines. So the question is, what is the gold standard for measuring platelet aggregation? I'm on stroke back up, and somebody is going crazy. Let me just, you mind if I just do that? 17-year-old girl with a stroke. No, I don't, because she's beyond the intravenous TPA window. Her stroke onset, her symptom onset was at 8 o'clock this morning, but she's within the 6-hour window, so she's a candidate for intraarterial if she has an occlusion. So the steps now we'll take is we'll get an emergent MRI and MR angiogram. If we see an occlusion, she'll have a conventional angiogram, and if she has a thrombus there, the choices are intraarterial thrombolytics or clot extraction using what's called a Mercy device, which is a little corkscrew that you put into the clot and extract. 17-year-olds are much more likely to have dissections too, so she may have a carotid, she may have a dissection. And she did start with some headache, or it could be migraines. Okay, back to the more mundane aspects of stroke.
Yeah.
These are the more exciting ones. Clopidogrel. So that's the story with aspirin. And I would say personally that the jury's still out on the platelet aggregation study. There are stroke experts in this country who do platelet aggregation studies on their patients who come back to the clinic on a routine basis, and they make adjustments in dose and choice of antiplatelet agents based on those results. But I personally believe, and I'm talking with my hematology colleagues who have much more expertise in antiplatelet therapy than I do, they're more conservative. So I don't do antiplatelet studies, platelet aggregation study. Just to refresh your memory, this is an old study now, over 10 years old. The Capri study that led to the approval of clopidogrel. 19,000 plus patients, a large study by our stroke standards, but it included patients with a stroke history, with coronary disease history, and with established peripheral vascular disease history, randomized to clopidogrel or aspirin, followed for 36 months, and there was a statistically significant 8.7% risk reduction. And this is the single large study that led to the approval of clopidogrel or Platelets for marketing in this country. The study included all patients. This slide, series of bar graphs, breaks the patients down into those who were enrolled with stroke, those were enrolled with MI, and those were enrolled with peripheral arterial disease. And I think it makes 2 points. One point is the stroke patients have the highest risk for subsequent vascular events, which is not particularly surprising because they're older. Stroke patients tend to be 6, 7, 8 years older than the MI patients. And the second point it makes is that with stroke and MI, your index event in the next 3 months predicts what your likely next event. So if you had a stroke, you're more likely to have a stroke event in the next 3 years. If you have an MI, you're most likely to have an MI. Now, this comes up because sometimes we hear people say, well, even if you've had a stroke, your greatest risk is that you'll die of a myocardial infarction, which is probably true if you live longer. I mean, once you get out to the 4, 5, 6 years and beyond, your risk of stroke has declined, and your risk of myocardial infarction has gone up, so that the two become equal or MI increases. There was, and is still, a wave of enthusiasm, particularly among cardiologists, for combining clopidogrel plus aspirin. And that was based on a very nice study, the CURE study in acute coronary syndrome patients that you're as familiar with as I am, I'm sure. We in neurology started applying the same philosophy in our stroke and TI patients and saying, okay, well, if one works, maybe two is better. Works in different sites of the platelet. And so maybe we should start using a combination, and many of us did. And particularly, say, a patient who's been on aspirin and they come in and they've had another event, we would just add clopidogrel. But a couple of studies were done. One is the MATCH study, and these were TI or stroke patients who also had some other high-risk cardiovascular risk factor. They were randomized, everybody got clopidogrel, and half the patients got 75 milligrams of aspirin, and half got placebo. So this is clopidogrel plus aspirin versus clopidogrel. They were followed for 18 months. The primary endpoint was ischemic stroke, MI, vascular death, and the need to be rehospitalized because of some ischemic event. So you had a quick MI or TI or something that required you to come in the hospital. There was an insignificant, statistically insignificant 6.4% risk reduction favoring the combination. So while there was a little trend in benefit, it wasn't enough to reach statistical significance, but still it was a trend. However, the problem was we could maybe live with just a trend and many people would have continued to use the combination, except when you look at the bleeding and you look at the combination versus clopidogrel only, there was an increased risk of life-threatening major hemorrhages and intracerebral hemorrhages in the combination. And then if you do these kinds of analysis here where you construct a sort of a net benefit analysis where the yellowish, greenish part of the bar represents the benefits in terms of thrombotic events, and the red represents the downside in terms of hemorrhages, you can see that the hemorrhages really the major life-threatening hemorrhages really offset the benefits in terms of reducing thrombotic events. The next study that is relevant was the Charisma study, and this is reminiscent of the Capri study. For a couple of reasons. One is it included patients not just with stroke, that was one of the inclusion criteria, but also with coronary disease, also with peripheral arterial disease, and then had another group who hadn't had any of those symptomatic vascular events, but just had a constellation of high-risk features that would put them at increased risk, and therefore, one would surmise that they might need more aggressive therapy. Here the patients, everybody got aspirin, and half the people were randomized to clopidogrel. So this is clopidogrel plus aspirin versus aspirin only. The primary outcome was stroke, MI, or vascular death. You can see again there was a slight trend. The placebo plus aspirin 7.3, clopidogrel plus aspirin 6.8, not statistically significant. If you look at the subgroups, none of them were really statistically significant. Stroke non-fatal, yeah, barely. It was a negative study. And again, if you look at the bleeding risk, the downside of this combination of aspirin plus clopidogrel, you can see certainly moderate bleeding was increased and severe bleeding was getting close to significant. One of the subgroup analyses was done, and here the customary cautionary note that you have to be very careful about post hoc subgroup analysis, although this was a planned subgroup analysis. Nevertheless, if they divided the patients into those who were asymptomatic, that is, they just had a constellation of high-risk features without a symptomatic event, and you compared on the top, that was 3,200. If you compared those to the patients who were already symptomatic, they'd already had a stroke or an MI, or they had symptomatic peripheral vascular disease, you can see that the symptomatic patients did reach statistical significance, just barely, an absolute 1% reduction, whereas the asymptomatic patients actually were statistically significant in favor of the aspirin-only group. So people don't quite know what to do with this. Some people have taken this at face value and said, well, it means that there are some patients with stroke or MI, with stroke particularly, who would benefit, but the asymptomatic patients are best just treated with aspirin. That's in fact what we tend to do. The aspirin part. We tend not to put people in combinations most days. So these are the quotes taken from the conclusions of the New England Journal article, saying that the combination was not significantly more effective than aspirin alone, that the risk of moderate and severe bleeding was increased with the combination, that there was some potential benefit in just the symptomatic patients, but as always, the findings need further study. So based on this, many of us have quit using the combination except in unusual circumstances, whereas we were previously very ready to add clopidogrel to aspirin and use the combination in stroke patients. Now we realize that we increase those patients' risk of intracerebral hemorrhage and major hemorrhage, and so we tend to use one or the other rather than a combination. The other combination agent is Agronox, and it was approved based on this study, which is the European Stroke Prevention Study 2, done in Europe. TIA, or non-disabling stroke patients, 6,600 of them. It had a 4-arm randomization that included a placebo group, a low-dose aspirin group, 25 milligrams twice daily, and this study is the basis for the lower end of the aspirin dose recommendation of 50 milligrams, because that dose was significantly beneficial in reducing stroke in and of itself. The third group was just extended-release dipyridamol, 200 milligrams twice daily. They chose extended-release dipyridamol in order to maintain this therapeutic blood level that I mentioned with dipyridamol. And then there was a combination of it. The primary endpoints were stroke and mortality. Mortality was really not significantly different, although you can see all of the active treatment groups were a bit better than the placebo group. If you look at the active treatment groups, each of them was significant. Aspirin alone was significant, with a 19% risk reduction. Dipyridamol alone was significant with a 16.5% risk reduction. And the combination was significant with a 36.8% relative risk reduction, which is really an additive effect of dipyridamol and aspirin. What about the downside, the safety? And here, if you look at the blue bars, you could see that even a dose of 50 milligrams of aspirin increases your risk of bleeding, almost doubles it. And then the two major side effects that are seen, actually the one major side effect that is most limiting in the use of Agronox is headache. 15% or more of patients who go on Agronox or go on diclofenac in any form will get a headache. Diclofenac is a vasodilator, and when you first put people on it, they get this, some of them, get this pounding vascular type headache. The good news is if they're able to tolerate, or if you're able to persevere for the first 4 to 6 weeks, then that headache goes away. But many patients won't or can't. And so it's been really the safety adverse effect that's limited the use of Agronox more than anything else, I think. The patients come back, and even though a lot of times we titrate patients, we start them on just one a day for 5 to 7 days, put them on give it in the evening, give some analgesic with it to try to get them through this period of the first week or so, and then maybe they can tolerate it. Some people that works in, some it doesn't. It's been a limiting factor. But it was only one study, and that was one of the criticisms of SPS2 and Agronox marketing. The ESCRI study is again a study that was done predominantly in Europe. 2,700 plus patients with stroke or TIA within the past 6 months who were followed for 3.5 years. And they were randomized to aspirin, and the range was anywhere from 30 to 325. This reflects the European preference for low doses of aspirin. In the Netherlands, the most common dose of aspirin used for stroke prevention is 30 milligrams a day. So they're proponents of what we would call very low doses of aspirin. Compared to aspirin plus diclofenac, 200 twice daily, generally that was extended release diclofenac. There were some parts of the world, some countries where immediate release diclofenac was used. The primary endpoint was the combined vascular endpoint, cardiovascular death, stroke, and major bleeding. So they incorporated major bleeding so that basically the net benefit analysis was their primary endpoint. 16% of the patients on aspirin had a primary event. 13% on the combination had a primary event. There was a 20% risk reduction. So this had results in terms of the risk reduction compared to aspirin with the combination of aspirin plus diclofenac that was almost identical to that of ESPS2. So a lot of people saw this as confirmatory or at least supportive evidence that the results of ESPS2 were probably correct. Turn for just a little bit to Warfarin. This is an old ad for, I'm sure you realize that Warfarin for many, many years was an extremely successful rat killer. And because of that stigma or knowledge, there was a lot of reluctance to start using this in people. It finally was, and while we use it mainly, the best indications are for cardioembolic stroke. There were a lot of people who were using it for vascular disease. Is that me?
No, I think it's Dr. Chads by me.
Okay.
She got patient.
And I'll just show you the summary of a couple of studies that looked at the use of warfarin in patients with non-cardioembolic mechanisms for their stroke. The WARS study was 2,200 patients who'd had an ischemic stroke in the last 30 days without a cardioembolic source. So these were the routine patients that we see. A lot of them had lacunar strokes. Some of them had cryptogenic strokes. Most of them didn't have major extracranial vascular disease that needed an endarterectomy, but some had intracranial vascular disease. They were randomized to warfarin or aspirin. Some would argue the target range for warfarin was a little low. The mean was 2. as opposed to 2.5 that we would usually target for cardioembolic stroke prevention. And here are the event curves over the course of the study, and you can see that aspirin, not only was warfarin not better, aspirin was slightly better, not significantly so, than warfarin. Okay? So the people who actually designed and executed the study had been big proponents of warfarin in these particular patients. And so this was disappointing to them that they didn't find that warfarin was better than aspirin. And we don't care if it's the same as aspirin, because aspirin's a lot easier to use. We only care if warfarin is significantly better. So it was a negative study. So it should have caused us to consider warfarin in non-cardioembolic stroke patients only extremely rarely under unusual circumstances, whereas some people are doing it routinely. I think some of the most important information that came from the WARS study, however, were the subgroup analyses, and one had to do with antiphospholipid antibodies. These antibodies lead to a hypercoagulable state, and there is no doubt the antiphospholipid antibody syndrome that is a real disorder. Young women with recurrent DVTs and spontaneous miscarriages and antiphospholipid antibodies, and the tradition is that they're treated with warfarin long-term, and it's beneficial. The question is, what about antiphospholipid antibodies in this particular population? So these are 65-year-old patients with hypertension and diabetes, and lots of them with leukemia strokes or ischemic stroke. So they looked at antiphospholipid antibodies in these patients and followed them over the course of time, with the questions being, does the presence of an antiphospholipid antibody in one of these stroke patients increase the risk for subsequent stroke, first? And you might think it would if it renders them hypercoagulable. And secondly, based on the anecdotal experience with antiphospholipid antibody syndrome patients, you'd expect that they might do better with warfarin than they did with aspirin. So they looked at all the patients with antiphospholipid antibodies, and there were a lot in this age group who had positive studies. And the bottom line is, it didn't make any difference. The presence of antiphospholipid antibodies didn't predict that somebody was going to have an increased risk of stroke, nor did it predict that these people were likely to have a greater benefit from warfarin. So the bottom line is, don't order it unless you have some strong reason to suspect in this population, in the 65-year-old stroke patient with hypertension and diabetes. Now, the 17-year-old that I just heard about with stroke, yeah. I mean, looking for hypercoagulable disorders is a very important thing to do in young people with stroke, but not in this population. The second question had to do with patent foraminal valve, paradoxical embolus, and the idea, and again, there seems to be no doubt, based on mainly case control studies, that if you're young, less than 50, and you have a cryptogenic stroke, that is, you don't have obvious mechanisms for your stroke because you got premature athero or long-standing diabetes or hypertension, for example. You have a cryptogenic stroke. If you have a PFO, particularly if you have a large PFO, and if you have a PFO associated with an atrial septal aneurysm, you're at increased risk for stroke. And you probably need to be treated with warfarin, although that's never been really subjected to a good randomized trial. So the question is, what about in these patients? So they convinced 625 or so of these patients to undergo transesophageal echocardiogram, done in a standard way, sent to a central reading center, documented whether they had PFO, how big it was, whether it had an atrial septal aneurysm. Bottom line, didn't make any difference. They didn't have an increased risk of recurrent stroke. They didn't do any better with warfarin. So the first question that people asked when this was presented, I remember, was, What about the big PFOs? Because in young people, that's important. Didn't make any difference. Size didn't make any difference. What about the ones associated with atrial septal aneurysm? Didn't make any difference. So the bottom line for me is, you get an echo back on a patient with stroke and it says the person has a small PFO. I don't think you need to do anything. I don't think it needs to influence your therapy. Now, if you tell me that the stroke occurred in the setting of the DVT and a valsalva maneuver and the patient also had a pulmonary embolus, I'd say, it's a different story. But the average patient who doesn't have evidence of a DVT, no reason to think they had a paradoxical embolus. The presence of a patent frame shouldn't influence your management. You're just going to treat them with an antiplatelet agent. Now, there are places in this country where there are studies underway looking at the closure devices for PFOs following stroke. And there are a lot of places in this country where people are very enthusiastic about closing PFOs. And not just the young people where they probably may well have a benefit, but even in older patients. And I personally think that's a little bit too aggressive. The other study that's relevant is the Wasab study. And think of it as a selected subgroup of the war study, because these were people who had a documented intracranial stenosis. And in this angiogram here, you can see that this person, indicated by the red arrow, has a greater than 50% stenosis of their middle cerebral artery. And the party line was based on case studies, anecdotal series, was that these people were at very high risk for stroke recurrence. And it makes sense. When you've got a significant intracranial stenosis and a major vessel in the brain, and you're likely to have a stroke. And the party line was they did better on warfarin. And so these patients were subjected to a randomized trial, warfarin versus aspirin, and in this case, high-dose aspirin, 13 milligrams a day, so nobody could argue that the dose wasn't adequate. The study was stopped by the Safety Monitoring Board because there was no difference in the outcome events, 2 years, absolutely no benefit to warfarin, and in addition, there was an increased risk of death and an increased risk of bleeding in the warfarin patients. So, no benefit of warfarin over aspirin in these patients. Deaths and major bleeding were increased. One of the controversial aspects of the study was that, and many of us were at the time critical of the DSMB for stopping the study early because a large component of the increased death rate in the warfarin-treated patients were non-vascular deaths. And we've had years and years of experience with warfarin, and as far as we know, it doesn't cause cancer, it doesn't cause suicide, and it doesn't cause car accidents and things like that. Non-vascular events. So I think that was a random occurrence, chance occurrence, but nevertheless, even if you ignore that, there was no benefit and the death rate was increased. What time do you guys finish? I can stop anytime.
We usually go to 15 years.
Okay. We'll do a little bit more here and focus for a minute on cardiobolic stroke, in particular atrial fib, which is the major component. Almost half of all cardiobolic strokes come from atrial fib. And this is particularly relevant in your population because if you look at the number of patients in this country with atrial fibrillation, the median age is 75, which means that half of all the patients with atrial fib are over the age of 75. And if you look at, I have another slide which is I don't have here, and if you play out the projected prevalence of atrial fib over the next 20 years, it's going up. Because the population is aging, the risk goes up with increased age. Coronary disease, people aren't dying so much from their coronary disease, so the two big epidemics from cardiology or congestive heart failure and atrial fibrillation. So this is a disorder that we're going to have to deal with. There are a number of schemes that have arisen out of the randomized trials that have addressed the issue of predicting a patient's stroke risk as a means of guiding whether or not the patient needs to be on warfarin. And currently, probably the best one is called the Chads2 Score. And Chads2 stands for the different components of the score: congestive heart failure, hypertension, age, diabetes, and stroke. You get 1 point for everything except stroke, where you get 2 points. And some people think that probably you should actually get 3 points for stroke if you look at the risks that are generated. So these are fairly easy, clinical features to discern in a patient, and you just give them points based on whether or not they have any of these. And then if this was derived from one data set and then confirmed in another data set. So so far this looks pretty consistent. And it's pretty consistent with the guidelines that were generated by the SPAF studies that were done, coordinated out here, and a number of other studies that have looked at aggregate data from the different trials. So if you look at the score on the left there, from 0 to 6 are the possibilities, and then you look at the adjusted stroke risk, you can see that if you have a score of 5 or 6, you're talking about a 12.5% to 18% annual risk of stroke. That's high. And it's unlike some mechanisms of stroke, the risk of stroke with atrial fibrillation goes up every year rather than goes down after the stroke. After a couple of years after an ischemic stroke from some other mechanism, large artery disease, your risk goes down. With atrial fib, your risk keeps going up because age is a powerful predictor. So that now most people would say anybody with a score of 2 or greater, some people would even say 1 or greater, but most people would agree that 2 or greater on the Chads2 score should be considered for anticoagulation with blood. What's the range? The range is based on a number of different studies. These are case control studies. And it basically shows that if your INRs fall below 2, you increase the risk for ischemic stroke. If your INRs begin to rise above 4 or so, your risk of brain hemorrhage increases, and thus the target range of 2 to 3. Some people would say because age is also a powerful predictor of risk of brain hemorrhage, that patients over the age of 75, you should target a bit lower, like a 2 as opposed to 2.5. But as we all know, it's not easy to dial in an INR and keep the patient at a given INR. It's almost impossible. Very briefly, because you guys, I'm sure, deal with TIAs, and a couple of, I think, very interesting studies with respect to TIA prognosis. One is from Johnston in San Francisco. He looked at the Kaiser Permanente ER database in Northern California, 1,700 patients who had the diagnosis of TIA in the ER, and then he followed them up and looked at their records, and 10.5% of them developed a stroke within the first 90 days. Okay? And more importantly, half of those, 5% of them, 5% absolutely, developed stroke within the first 48 hours. So it emphasized the emergent nature of a TIA and the need to work them out, some of them at least, very promptly as opposed to taking a leisure attitude. So that in 90 days, the risk was significant. The risk factors that predicted stroke, the important ones were age over 60, diabetes, longer TIAs, those lasting longer than 10 minutes, and the features of the TIA, if the person had weakness or speech changes. So here we see the events In 3 months, there's the 5% that occur in the first 48 hours. And the independent risk factors, again, are age over 60, diabetes, long duration, weakness in speech impairment. Why weakness in speech impairment? Probably because they predict patients with true TIAs. I mean, we all see these patients who come in with dizzy spells and some blurry vision, staggering. And yes, that can be a TIA, but it can also be 423 other things. But a 15-minute episode of garbled speech and right hemiparesis is probably going to be a TIA. So it probably has to do with the validity of the TIA. And so here are the risk factors and the number of risk factors present in the prediction of subsequent stroke. And you can see if you have 4 of those important risk factors, you have a 3-month risk of 15%. If you have 5 of them, you have a 1/3 risk, 34% risk. The other study that I think essentially validated this, vice versa, came from the Oxfordshire Stroke Project. And these patients are with suspected TIA in this community are all referred to a TIA clinic. And they were evaluated, and basically they developed what they call the ABCD score, which has many of the same features. A stands for age over 60, B stands for blood pressure, hypertension, C stands for the clinical features of weakness or speech changes, and the duration is greater than 60, 10 to 59, and less than 10. So they looked at it a little bit more discriminatingly in terms of the duration and did the permanente group. And so with the ABCD score, if you have a score of 0 to 4, your risk in the next 7 days of a stroke is less than 0.5%. If you have a 5 or a 6 on your ABCD score, you have a 12% risk or a 31% risk. And these are pretty close to what was found in the causal permanente group. So that I think for practical purposes, we see a patient in the clinic or we see a patient in the emergency room with a TIA. We do these scores either in our head or from a piece of paper or whatever. And if we find scores that suggest that this patient has a very significant increased risk for stroke, then that person needs to be treated aggressively. Conversely, if they're 45-year-olds with a 1-minute episode of lightheadedness and dizziness and no diabetes and no hypertension, this would suggest that they have a very low risk of stroke in the first 7 days. And so maybe you don't need to be quite so aggressive in working those patients out. So what we would say that anybody with a score of 4 or 6 for sure, we would admit those patients. We admit them in our system because we can't get all these studies done in the emergency room. If you're in a system where you can actually get a carotid ultrasound or an MRI angiogram and an echocardiogram in the ER or within hours, then you might not need to admit the patient. But basically, we're looking to discover those patients who have a significant carotid stenosis that needs to be treated with some revascularization approach, endarterectomy, for example. The patients with atrial fib who need to be anticoagulated. The patients with some other major cardiac source of embolus other than atrial fib, valvular disease, left ventricular thrombus, ventricular aneurysm, and so on. Okay, let's go through this. So, to summarize, really the most important thing to do that's from the public health perspective is to manage the risk factors. So, the primary care physicians who are encountering these patients with hypertension, diabetes, detecting their atrial fibrillation, they have the greatest opportunity to prevent stroke as opposed to the stroke neurologist who sees them oftentimes after the fact. So that the strategy is to determine what risk factor they have that puts them at risk, and then to develop the treatment, the preventive strategy based on that. So if somebody has AFib and they have a high Chads2 score or a score of 2 or greater, and they're a candidate for warfarin, you put them on warfarin. If they have a significant carotid stenosis and a TIA, you send them for an norepinephrine. And then one of the biggest problems is, as well or better than I, is the compliance. That in the long term, trying to keep these patients under good control and in target with their hypertension management, their diabetes management, and lipid management, and their exercise program, and their smoking cessation program, that's the challenge in these people. And a number of reasons for that. Physicians have to take some responsibility. The patients are non-compliant for various reasons, side effects, cost, etc. Okay, I'm going to stop. Answer any questions or address any.
You got an expert
Cases.
asking questions now.
I got several questions.
Yeah.
One, you didn't say anything about the potential of SSRIs to be used as antiplatelet drugs. Do you know anything about the state of that?
I don't know that. I know that there's some evidence that they have some antiplatelet effect, but they've never been studied, nor have I ever seen
I thought there were clinical trials going on.
with SSRIs
Yes.
for
For
primarily
prevention.
focused on stroke prevention. There may be, but
The next one is that I'm increasingly skeptical of effects, clinical effects that require thousands of people to be studied for almost decades to show
yeah.
effect. What do you think of that? I mean, it looked to me like in the, let's just say the cholesterol lowering trials, they're treating 5,000 or 6,000 people 5 years to make a 20% reduction on a highly selected group. They're not just all comers, they're people who have already had a stroke,
Right.
and the incidence of stroke was only 15% in the placebo group. So that means that 85% of people exposed to those drugs 5 years would never have had a stroke.